And we're going to go right here. Looks like we're live. Hello, my friends. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. Today is Sunday, September 17th, and it's time for another live support group meeting. Now, my purpose in doing these meetings is to open some new doors, open some new windows, show you that perhaps there might be other therapies for you to try if current treatments are not working. It's to help you understand the concept of cause versus effect, that your symptoms are the effect. We have to focus on trying to understand underlying causation. That's very, very important because we don't want to just chase your symptoms for years and years. What we want to do is fix the underlying problem, right? Okay, here, hold on a sec. I've got a little bit of tension here in this microphone. We are currently simulcasting on YouTube and Facebook as we speak. So if I'm looking straight ahead, I'm looking at Facebook. If I'm looking over here, I am looking at YouTube. Hello, Donna. Nice to see you, hon. Nice to see you. Okay, here, hold on a second. Are we good here? All right. For those of you on Facebook, if you could just let me know if you can hear me, that would be great. Hi, Gay. How am I doing? I'm okay. I'm okay. For those of you who might be just watching this during the first time, I was a caregiver for my elderly parents for many years, and I lost them a couple months ago. So grief is like a Mack truck, but it's also real slippery. I mean, it's like, you know what it is? It's like playing whack-a-mole. You got some days where you're fine, and then some days where just like the littlest thing will trigger tears. And so I'm doing okay. Gave my dad's car away to my nephew, and yesterday I gave a good portion of her clothes away to one of her very, very dear friends. So we are making progress, and I feel them all the time. I do. So normally when I do these meetings, I usually do a little 30-minute intro, and then I'm happy to take your questions. I'm always happy to take any questions you might have. I want to start out this meeting by talking again about COVID cystitis because, and I'm not sure if I talked about it last weekend or not, we had a father of an 8-year-old who got COVID and is now struggling with a variety of long COVID symptoms, including urinary frequency urgency. This is called de novo cystitis. This means that this patient had no previous history of bladder issues until they got COVID. And so this little boy is struggling. He's slowly doing better. But once again, I reached out to our top IC doctors around the country. They all responded and said that it appears that COVID cystitis is short-lived and that it usually resolves in the great majority of patients out there. And so that was very encouraging for that young father to hear that his son was having trouble sleeping and all that sort of stuff because he was using the restroom all the time. And that's always really heartbreaking, when you've got a child. When we think about cause and effect, and when we think about age groups, there was a paper earlier this year which really talked about what do doctors normally see based upon the age of the patient reporting their symptoms. And that doctor said for children, teenagers, and people in their 20s, we're really looking at trauma. That usually, or for the majority of patients, that there is some sort of major physical trauma. Hi, Erin says, thanks for all you do. You're very welcome, Erin. Hello, Danielle. Hi, Renee. And then for patients in their 30s and their 40s, we're potentially looking for kind of the more classic bladder wall-driven symptoms, some frequency urgency signs that nerves have been inflamed, what we would call overactive bladder. And for those of you on YouTube, let me just adjust this camera a little bit. And then for patients, for women in their 40s and beyond, we're going to look at estrogen atrophy as an underlying cause, et cetera, et cetera. Stacy says, have I dyed my hair? Nope, this is it. This is the real thing. She says, it looks so pretty. You keep strong, beautiful. They are always with you. Yeah, they are. It was amazing talking with you the other night. Can't thank you enough. Yeah, I've been doing a lot of Zooms with patients abroad also. I really enjoy it. Thank you. Thank you, Renee. So this brings up another patient that I worked with this week. And this was a patient, I mean, this is so classic for so many of you. So this was a patient in her, I think she was in her mid 40s, or her symptoms started in her mid 40s. And you know, what's my favorite question? Is there an event that you associate with the onset of your symptoms? And her answer was not really, no. So we started going through the subtype because she kept saying, Jill, nothing's worked for me. Nothing's worked for me. What do I do? Nothing's worked for me. And I'm like, well, we can't pick the right treatment until we understand your underlying anatomy here. This is why we do something called phenotyping or subtyping. And because she'd been diagnosed 10 years ago, she had no idea what that was. She had no idea that there were distinct patient groups. And so you know, you guys are kind of like a needle in a haystack whenever I work with you. It's always hard to try to see the forest for the trees, for lack of a better term. I mean, it's always a challenge. Okay, so anyway, we go over Hunter's lesions. No history of lesions. She had, I think, 2 hybrid distensions, normal bladder, a little irritated bladder, but basically a normal bladder. Okay. We go through bladder wall driven symptoms. So we look for chemical injury of the bladder. And this was a patient who, honestly, she said she drank a ton of diet soda. And we know artificial sugar, especially NutraSweet, is metabolized into formic acid and formaldehyde. That's going to irritate the hell out of your bladder. So there is a toll to be taken to the bladder wall when you keep putting a very strong acid on that tissue. Remember, your bladder was designed thousands and thousands of years ago, before the invention of diet sodas, before the invention of artificial sugars. And these chemical compounds have the potential of being metabolized into kind of toxic substances. Another good example of that is ketamine. Ketamine, if used in very small doses, can help with pain and depression and anxiety, perhaps, but when used in large doses or taken recreational, actually acts as an industrial solvent to the bladder and damages tissue. Okay, so we go through the chemocystitis, but she had stopped the diet soda years ago. And so really any of the damage that diet soda would have done is probably long healed. Yeah, she could have some sensitivity from those nerves that were being tweaked over and over again, but any superficial damage from the acid had to have healed by this time. So then we go over the pelvic floor subtype. Okay, are there any events that you associate with the onset of your symptoms? Have you had any falls, anything at all like that? And the answer was generally no. Were you an athlete? No, not really. Okay, and when you ask that question, when is your pain the worst? Before you urinate or after you're done urinating, her pain was worse. Gosh, how did she answer that question? It wasn't clearly pelvic floor. She could start her urine stream right away, and her pain was worse on bladder fill. If your pain is worse after you're done peeing, that points us to pelvic floor. If you can't start your urine stream right away, that points us to pelvic floor. So she didn't trigger pelvic floor, I mean, substantial pelvic floor alarm bells. There might have been a little. Then we get to pudendal neuralgia, positional symptoms. How are you when you sit down? Do you have pain when you sit down? Does it get better when you stand up? And she had a little bit of that going on. It's like, okay, have you ever had a pelvic floor assessment? And the answer was absolutely not. And I said, well, it would be fascinating to see what's going on with your pelvic floor. And I encouraged her to just get a pelvic floor assessment anyway. I mean, she wasn't triggering it massively, but there was a little bit of some. So why not? A little bit of some. And in our conversation, she references anxiety, lots and lots and lots of anxiety. And then she references that she's got other pain conditions. Jill, you're not going to believe what's happened to me. I've got all this stuff going on with me. Oh, light bulb. So we started talking about IC subtype 5, widespread pain. And this is using the CRISP pain subtyping or phenotyping system. So I asked her, I said, do you have really sensitive skin? She goes, yeah. You have a wicked sense of smell. Yeah. How did you know that, Jill? And it's like, because I do too. Do you struggle with anxiety? Massive anxiety. You struggle with catastrophizing? Yes, terrible, terrible catastrophizing. So what did that tell us? What that tells us, and then do you have multiple pain conditions? Fibro, she had fibromyalgia, she had lots of other things going on too besides the IC. So what that tells us is that she is a chronic overlapping pain condition patient. If you have 2 or more of these related pain conditions, your official diagnosis is chronic overlapping pain, right? Okay. So this then, begs the question, why does this happen? Why are there some children who end up with multiple pain conditions? And what the research shows is for about 80% of those kids, there's a major physical trauma. Major physical trauma. And for the other 20%, there's a history of abuse or bullying. And that's triggered lots and lots of sadness because it turned out that she was sexually abused by an abuser, and she had a very violent father when he drank. And she told me that she would hide in the closet because she never knew what he was going to do. So in our research with chronic overlapping pain conditions, we have the fabulous Chronic Pain Research Alliance. They were convened about 10, 12 years ago by all the pain organizations to try to figure out why do these pain conditions often occur together. I mean, this is one of my subtypes for sure. And they started studying first the nerves in the pelvis. Then they moved to the nerves in the spinal cord. And then they nerved to the central nervous system anchored in the brain. And that's where they made the discovery that patients with widespread pain are stuck in a vicious loop of fight or flight and anxiety. Fight or flight and anxiety. So think about this. For a moment. Imagine being a young child, knowing that when you get home and your brother gets home from school, he's going to hurt you. He's going to abuse you. That little child's brain immediately goes into fight or flight. And she had no one to tell. And so her safe place was at school. Her scary place was at home. And her scary place was at home for decades. Probably for about 20 years until she moved out. And these are these moments that are just, it's so important that we say to you, this is not your fault. You have done nothing wrong. You were hurt. Chronic overlapping pain conditions is considered a central nervous system maladaptation. It's not mental illness. There's nobody saying that mental illness is causing these symptoms. This is instead an injury to the central nervous system. This is what happens when your brain gets stuck in fight or flight. 14 days of pain will put your brain into a constant state of fight or flight, 20 days of bullying. Even if you're an adult and you have a bully at work, if it goes on for more than 20 days, you're going to go into fight or flight for an extended period of time. And of course, there is a ripple effect to that fight or flight. And that is your body's preparing normally fight or flight's temporary. It's supposed to only last a very brief period of time. Do you open up your front door and you see a tiger? Of course, your brain is going to go into fight or flight. It has one job, to save your life. This is the brainstem. This is the sympathetic nervous system. But you're smart. You're an adult. You slam the door. You call the authorities. Hey, there's a tiger out here. I need help. They come out. They trank the tiger. They take it away. An hour later, the tiger's gone. The threat is gone. And it's at that point in time, fight or flight is supposed to turn off. And the calm part of your brain, the parasympathetic nervous system, is supposed to take back control. The parasympathetic nervous system relaxes your muscles. It lowers your blood pressure. It lowers your heart rate. But for those of us with chronic pain, that is not happening. We are stuck in fight or flight. So what does fight or flight do? It tightens your muscles. And in her case, she had always had pain with intimacy. She had always had pain having a gynecological exam. She had been diagnosed with vaginismus. Why? Because her brain was protecting her. Her brain was getting her ready to run for her life. And interestingly, too, we've wrapped up our first Meet the IC Expert lecture again, this time on video. We've done about 100 Meet the IC Expert lectures. And I'm just starting them up again. We did our first one with, here, hold on, let me get her book. Where did I put her book? Here it is. Dr. Martha Boone. Martha Boone. And I asked her, and you guys will be able to see it soon. It'll be on YouTube. I'm just waiting for a new video intro that's being made for us right now. I asked her, what's the most important thing that patients ignore, that patients do not do, that they should be doing? And, she flat out said, we got to work on the anxiety. We got to work on the catastrophizing, because every time you do that, you put your brain right back into fight or flight, which intensifies your pain. That we have to focus on calming our central nervous system down. That when we calm our central nervous system down, pain reduces. And again, nobody's saying that this is all in your head. Nobody. But what we are saying is that trauma begets challenges. And y'all know my story. You know my story. I grew up in a neighborhood with a kid who later raped and murdered my neighbor, and I was one of his early victims. I did not leave my home without fear for almost 15 years. And literally, probably not too long after I went away to college down in Southern California, he murdered my neighbor. Imagine what that did to my brain. Thus explaining why I had frequency urgency as a kid. Thus explaining why I had vulvodynia, an irritation of the vulva, feeling like I had a yeast infection all the time. That was in high school, and that's because the muscles were squeezing nerves and reducing blood supply to my vulva. Thus explaining why I had IBS in my 20s. Thus explaining why the anxiety kicked in big time with the catastrophic thinking. Thus explaining the migraines. Thus explaining the bladder pain that I started developing when I was, in my early 30s. And the irony here, as I told her, is that my very first appointment, my wonderful urologist, Mark Klein, said, I'd really love for you to go and talk to a psychologist. And I just blew up at him. And I said, I'm peeing all night. It's a problem with my bladder. Do not even talk to me about what's going on in my head. I want to know what's wrong with my bladder. And of course, I begged him to take my bladder out. Thank God he didn't do that. But he was right. All you had to do is look at my history of the multiple pain conditions and the anxiety to know that I had a very injured central nervous system. And so being, as Dr. Boone said, we have to engage in that healing also. We're going to heal tissue in the bladder that's irritated. We're going to heal muscle with physical therapy. And we have to work on healing and calming down nerves. And we do that with mindfulness. We do that with mind-body medicine, maybe some medications too, like PEA. So getting back to this patient I was working with, she was absolutely gobsmacked. It's like, nobody's ever said that to me before. And I'm like, yeah, isn't it great? I mean, we now know it's not your fault. You did nothing wrong. We completely understand why this happened. And then it's about how do we turn it off? And the way we turn off fight or flight is with good sensory information. The language of the sympathetic nervous system is sensory information. You can't think yourself out of it. You can't say, hey, stop panicking. Not going to work. You can't say, hey, turn off amygdala. Not going to happen. The way you turn off fight or flight is by giving your brain good sensory information. What do you see? Is it a puppy or is it a fire? You need to visualize the puppy. What do you hear? Is it somebody screaming or is it your favorite music? What do you taste? Is it irritating or is it your favorite food in the world ever, ever, ever? What are you touching? Is it something hot that's burning you or is it your lover or warm sand? And as we embrace these mind body medicine techniques and these mindfulness techniques, we can absolutely calm everything down. Renee says, my mom died on September 4th. Oh, honey. Oh, honey, honey, honey. I've been working on relaxing the brain. Girl, it's so fresh for you. I mean, I'm 4 months in. You're barely 2 weeks in. And it's it's chaos. Everybody grieves in their own ways. I've never cried so much in my life. I was always the strong one. I mean, when I was in college and as an RA, I was the RA for the swim team. They gave me the swim team because they knew I was a tough person. But this, grief passes through that toughness. And if you ever want to talk, I'm here. If you ever need a hug, I'll give you one over the phone. One day at a time, hon. 1 hour at a time. Just breathe. Just breathe. And try to remember that one of the best ways we can honor those that we've lost is by doing something that they supported. So, for example, if your mother loved horses or animal rescue, getting everybody together to do a garage sale to raise the money for her favorite cause. She'd be smiling from above if you did that, right? Sue says, dialectical behavioral therapy, most people with chronic pain and also have a history of emotional abuse or emotionally unregulated or are emotionally unregulated, and this therapy is beneficial. Trauma lives in our body, whether you have the injury, physically or mentally. Usually a year-long program, which is group therapy with a therapist that helps you with a mind-body connection. Yeah, my anxiety is very, very controlled. But it annoys me that it's like whack-a-mole. It's just like, bam, there it is. There's that negative thought. And for me, it's like once a day. It's like a once a day negative thought, which I immediately do my stop sign deep breath, right? I never allow myself to have a lot of negative thoughts in a row because that kicks off fight or flight. But are we going to have the earthquake? Are we going to have a fire? Those are my negative thoughts right now, which is crazy. Anne says, can you use a pelvic wand rectally? Can you have IC without hematuria? You can use a pelvic wand rectally. You're just going to have to really clean it. I would probably even put it in a condom and put KY on top of the condom so that, you're keeping things very, very clean. And can you have IC without hematuria? Well, all IC means is that you have pelvic pain. So the correct question is, can you have pelvic pain without hematuria? Absolutely. Pain coming from your pelvic floor is not going to cause blood in your urine. Pudendal neuralgia is not going to cause blood in your urine. Chronic overlapping pain conditions probably not going to cause blood in your urine. All right. You guys on YouTube, you're being very quiet. So let me go back and look at some questions. Danielle says, what type of doctors can give you this answer? Well, very few, because this is very new. This is why you've got to be very educated and informed. Now, I got to tell you about another patient. Now, y'all know as a support group leader, people call all the time. And sometimes people call and ask me the same question over and over again. And like the first time I spend an hour with them, the second time it's like, Jill, what do I eat? Like, well, I know we talked about this. Yeah, but I didn't really understand. Can you tell me what I need, what I can't eat? Spend another half hour with this person. Month later, calls exactly again with the exact same question. It's like, no, wait a second, honey. I've already explained this to you twice. And she's like, yeah, I just need you to tell it to me again. I went, listen, have you been to our website yet? No. You can get all the diet information on our website. Well, can't you please tell me? And it's like, honey, my job is to give you half of the information, then kick you in the pants and get you to do your own research. So you need to come on over to our website and read the section on diet. Because I literally have 10 patients I've got to call, and I've already spent 2 hours with you going over this. Have you been to our website? Have you read anything? No. What's your website? Oh my God. Do you even know? And so, those are moments that always have me a little frustrated, because really what's happening in that case is that that's really a patient who wants you to do all the work. They don't want to do any work. And I'm on to that now. And it's like, not anymore. If you want to get better, you've got to become a part of your solution. I need you to read. I need you to start reading, to start educating yourself. I don't like to read. I don't care if you don't like to read. It's your job. You're an adult. You have to read. There's nobody who's going to spend 10 hours with you on the phone going through all of this. And so, especially, for free. I wasn't paid for any of that, obviously. So that's my little bitch session. It's if you keep calling with the same question over and over and over again, I'm going to say, have you been to our website? If you say no, I'm going to get a little frustrated. The IC Network website is rated #1 by Harvard Medical School and the University of London in peer-reviewed research studies. The information on there is rock solid. And I've been massively tweaking and updating this summer too. So go on over to our website, icnetwork.org, and start reading. In fact, let me move that so that you can see the. Stay. Okay. Aaron says, this makes so much sense to me in how I was raised. A father with a terrible temper, which caused lots of anxiety. I have chronic overlapping. Girl, honey, we're sisters. We're absolutely sisters in this. Not your fault. And now we understand how the central nervous system responds to that. And now we know where to direct our treatment. Because for you and I, we don't have a bladder disease and a bowel disease and this and that and this. And when you're the patient, you're going, what the hell is wrong with me? It's like every 6 months, something new. This really is just a manifestation of an injured central nervous system. And so you and I have to spend a lot of time working on our central nervous system. Lots of deep breathing, lots of good anxiety management tips, and being attentive to those moments when you are struggling with intense anxiety over and over and over again. That's when we do our stop sign, deep breath, minimize the thought technique, so that you don't get so much adrenaline floating through your body that it's making you crazy and making you cry and making you panic. The secret really is we've got to calm those negative thoughts down so that we can break ourselves out of fight or flight and just slowly but steadily calm that nervous system down. And I'm living proof that when you do that, things get better. I wish it would go away completely. I mean, I used to have a negative thought literally every other minute back in my 20s and 30s. Now I might have one a day. But that one a day annoys me. And I was driving up to Hillsburg this morning because I had to go get something. And, I was just starting to feel just a little stressed, a little headache. And I was doing my deep breathing in the car along with my some favorite affirmations. Most importantly is my dad is the co-pilot. He's going to keep me safe. And I'm loved. That's what I was saying really mostly today is I am loved. I am well. I am healthy. I am loved. Donna says, for IC Awareness Month, I bought Dr. Weiss's book for my pelvic floor physical therapist. I will surprise her tomorrow when I see her. I do this every year for my doctors. My guy gets my IC magazine. Donna, that's fantastic. Best book ever. Hi, Jeff. How you doing? Hope all is well. Sue says, I've been in that mode for 40 years. DBT therapy is very helpful when living with severe chronic pain if you can get your insurance to pay for it. Yeah. Dialectic behavioral therapy, which she said most people with chronic pain also have a history of assault or abuse, or they are emotionally unregulated, and this therapy is very beneficial. Trauma lives in our body, whether you have injury physically or mentally from that trauma or both. Usually a year-long program, which is group therapy, and with a therapist that helps you with mind-body connection. Like, I think I'm very curious if I can learn some new techniques that will calm that last little thread of anxiety down. But as Sue said, and the challenge here is your brain remembers everything. And all it takes is a little scent, a little sound to trigger it. I mean, your brain remembers it. I did a couple months ago, I recreated my walk to school when I was a kid, when I was so scared. Only this time I was walking as an adult with my child spirit next to me. And it was so freeing. It was so comforting to be able to say to that young girl who was so scared and so lonely, you made it. It's okay. It was never your fault, honey. Don't think that you're to blame for anything that has happened to you. And it was very cathartic for me to walk that walk again. I walked it slowly. I mean, I walk in that area all the time now. I mean, I still live in the same home, guys, because this is where I was taking care of my parents, and I will be here for the rest of my life. I love my home, but I still have some of these memories. Jeff says, pretty good, but having all kinds of issues. Heed says, my goodness, this is making me cry. Oh, honey, don't cry. I mean, there's a lot of abuse that has happened to us, for many of us, when we were young that should have never happened. And this is why we now practice something called trauma-informed care. We really have to have a healthy respect for trauma and how that leaves a legacy in our body. But as adults, the blessing here is I'm an adult now. It'll never happen to me again. I will never allow anything like that to happen to me again. And I always have to remind myself I'm not that vulnerable child anymore. I'm a kick-ass adult. And I know how to defend myself. And I have resources that I didn't have as a child. So I have to remind myself sometimes that it's okay. You made it. That happened 50 years ago. You made it. You're okay. Jeff said, you're still on Elmeron and antibiotics to calm that down. Honey, why are you still on Elmeron? Elmeron is known for now 2 very, very serious adverse events. The first one is blindness, retinal damage that can lead to blindness. And the second one is inflammatory bowel disease that can lead to you losing your bowel. You know, Elmeron was very popular 10 years ago. But even if you look at the research, it's not like Elmeron helped every patient that took it. And you look at the own research studies by the company and by the many different research studies that have been done, it's probably one of the most widely studied medications out there. There are some studies that give high effectiveness, but quite a few studies that show not much better than placebo. And when you look at our guidelines here, one of the things that that everybody's really acknowledging is if you suspect somebody has IC, well, 10, 20 years ago, you'd give them Elmeron, you'd give them the diet list, you'd give them an antidepressant, and you'd say, I'd see you in 6 months. But the harsh reality is that that didn't work for the great majority of patients out there. It didn't work. Why? Because for most of us, it's really not our bladder wall. It's related more to muscles and nerves. The bladder coating is going to be best for somebody with estrogen atrophy, somebody with a chemically injured bladder, maybe to coat the bladder to give it some time to heal. Although Dr. Boone said for patients with Hunner's lesions, once she removed the lesion, because she resected the lesion out of the bladder surgically, she often did rescue installations to help them. But most patients who were finding success with Elmeron had transitioned over to Cystomend or Bladder Builder or Bladder Rest or Cystoprotect. Why? Because they're a hell of a lot cheaper. People just couldn't afford Elmeron back then. And, thank God many of them did, because now that we know these side effects, it makes sense. Jeff said, since we last spoke, there's been no improvement. If I try to stop any meds, the burn is back with a vengeance. I just can't believe I have this. Jeff, refresh my memory. Did they look inside your bladder? And if they did, what did they find? Do you have Hunner's lesions? Hunner's lesions have been connected to viral infections now for some patients. And so we have a polyoma virus and the Epstein-Barr virus, where we have very solid research that suggests that viral infections in the bladder can cause wounds in the bladder, aka Hunner's lesions. And so now we've got researchers that are exploring antiviral therapy as treatments for patients with Hunner's lesions. We had our first study released this summer. So Jeff, refresh my memory here, because I'm sorry, honey. I talked to so many patients that I don't remember details. There are a few patients I might remember some details, but I work with about 10 or 12 a day. So Sue said, it takes a lot of practice. That's why the program is 1 year, especially if you've been living in chronic pain or trauma for a long time. Just to retrain the way you think about past trauma. And Rebecca, let's see, hold on a second. Hold tight, guys. I'll get to your things. Yeah, okay. Marilyn says, I talked to you at the end of July about chemotherapy. You had a lumpectomy due to breast cancer this summer. And I'm happy to report I did not require chemo. Yeah, woohoo! Yes, yes, yes. Praise the Lord. I had accelerated radiation treatment, only 5 days. I will soon be going on a hormone blocker, aromatase inhibitor. FYI, and thanks again. Okay, so Mary, when you're on the hormone inhibitor, now what that means is that you're not going to have a lot of estrogen going through there anymore. So your bladder wall is going to get very, very sensitive. You remember estrogen helps your bladder wall produce that nice thick coating of mucus. So that's how the bladder protects yourself. Remember, your bladder is like your mouth. It's a hollow organ that's wet on the inside. And that wetness has a very important role in bladder function because it acts to protect the tissue. So that's what we call the GAG layer, the glycosaminoglycan layer, or the mucosal barrier. Unfortunately, that mucosal barrier is estrogen dependent. So when you're young and have lots and lots of estrogen, you have lots and lots of mucus. When they block your hormones, you're not going to have the mucus so much anymore, which means your bladder's ability to defend itself is now compromised. And so it's going to be more sensitive. So diet's going to be very important for you. Very important not to be drinking any soda, any cranberry, any lemonade, any coffee, any green tea, anything at all like that while you're going through, while you're on that estrogen blocker. And doing something that will have a coating effect makes the most sense. Again, something like Cystomend. If your symptoms really intensified, you could do home bladder installations with heparin and lidocaine. But hopefully one of the chondroitin-based supplements will give you enough coating so that you won't need that. Kayleen, girl, counting down to my installation tomorrow. You can't stop peeing at night. Woohoo! Isn't it ironic? Yeah, we look forward to treatment. But yeah, we do. And I'm so glad you're getting it done. Marianne said, it's been a while since I've joined. I wish I could say it's because I've been feeling better, but I'm not. I'm a bit lost as I was going to physical therapy, and my therapist told me she doesn't know what else she can do for me as we're not seeing results. I don't know where to turn to. My nurse practitioner or the urologist, I've never been scheduled with the actual urologist, wants to do installations next, which I'm leery of. Thoughts on your next step? So Marianne, the key question that you need to ask a physical therapist is, were my muscles slowly improving, or did they always lock back down into tension? Because if your muscles always locked back down into tension, that's when we need to take a step back from muscles and we need to look at bones. So why is my pelvic floor consistently tight? Because my SI joint is not right. My left SI joint moves when it's not supposed to move. So my deep piriformis muscle locks down tight to hold that SI joint in place. So it could be something as simple as a bad hip, a bad SI joint, a broken tailbone, a tailbone that's out of position, a bad knee where you're limping, or a bad foot and how you're walking. And what Dr. Jerome Weiss found, which he talks about in his book, Breaking Through Chronic Pelvic Pain, for those patients who are always stuck in tension, 95% of them, it related to how they walked. They were not walking normally. And I have to show you my newest acquisition here, because now that my SI joint is fairly stable and I'm exercising almost every day, but I have to be able to walk well. I don't have fat pads on the bottom of my feet anymore because I was obsessed with the Stairmaster and I did it for 10 years and I broke up all the fat pads according to the podiatrist. So I have to have shoes that have a lot of padding, and I found them with the Hoka Bondies. Woohoo! Pink, baby. These are like walking on air. I don't know if you could see the name or not. See the name Hoka? I like to wear happy clothes. Those are happy shoes. I also love my orange shoes. Okay, so getting back to Jeff, if you remember, I was injured with a triple hernia followed by surgery repair and left with pelvic pain and the effects. Hundreds lesions, yes. So Jeff, we have to try to understand why you have the lesions. And we want to, so the first thing we want to do is we want to request a viral scan. It's a simple blood test. Let's see if you have any active virus infections going on in your body or any antibodies for something like Epstein-Barr. Those lesions could be the result of an active viral infection. So have you done that yet? Carol says, what type of estrogen am I using from the International Compounding Pharmacy? I use their propylene glycol-free, preservative-free estradiol 0.1. And it's cheap compared to Premarin. I don't even pay attention to it anymore. It's like $50 or $60 for 3 months, not including shipping. It might be $10 shipping. Um, but yeah, compounded estrogen is the bomb. Okay, so again, Marianne, for you, what I want to know is, are your muscles consistently locking back down into tension? If they are, we have to figure out why. Bad hip, bad SI joint, bad tailbone, bad knee, bad foot, bad ankle. And according to Dr. Weiss, when he found that patients were not walking correctly, and he sent them to podiatry, once they got the correct orthotics and that corrected how they walked, their muscle tension improved dramatically. Let me give you a picture. I can actually show you exactly what happens. Hold on. So why would a muscle... Here, give me a moment. I want to find this picture. Here it is. Okay. So I'm going to prove to you why your feet mess with your pelvic floor. Okay. So this is the book, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. Fantastic book. I think it's the best book ever written. It is a literal masterclass in muscles, nerves, and all the things that can happen when these are dysfunctional. And one of the things Dr. Weiss says in its introduction is Western medicine fails a typical pelvic pain patient. Why? Because doctors play in their sandbox. Urologists stay in the bladder, gynecologists stay in the reproductive tract, et cetera, et cetera. And he said that's not the reality in the pelvis, because nothing operates in isolation in the pelvis. Everything influences each other. And the muscles can tremendously influence how the bladder behaves, because if the muscles are tight and injured, they're going to cut off blood supply. And the bladder is going to become starved for oxygen and nutrition, which then causes the bladder wall to break down, right? Okay. So I'm going to prove to you how a bad foot will mess with your pelvic floor. Okay, so hold on. This is the healthy foot. And I want you to look at the shin bone. That is at 90 degrees from the ground, straight up. And then you can see the leg goes straight up. And yes, the femur does extend towards the outwards as it connects to your pelvic floor muscles here. Here's the pelvic floor muscle. Now look at what happens if your ankle rolls in. If your ankle rolls in, your shin is no longer perpendicular. Your shin is now at an angle. And that angle is exaggerated by the femur. And if you look up here and you look at the pelvic floor, you can see now that these muscles have been stretched out. Compared to this side, this muscle is probably an inch and a half longer than this muscle because of this bad ankle rolling in. So that's a firebomber flying over. That became the mystery of his career. Why do patients struggle with long-term pelvic floor tension? Okay, hold on a sec. I just gotta, give me a quick moment here. I want to see if there's anything I need to know about. Because when you live in fire country, you do not hesitate. A fire can travel 10 miles in an hour. So a firebomber just flew over. Did it? No, I'm wrong. It's a very similar plane to a fire beamer. This is a Beach Super King Air. It is not a fire bomber. Okay, there you go. See, that's PTSD. You hear a sound, it takes you back. So it's not a fire bomber. Okay, good. Okay, so getting back to Jeff, you've had all kinds of urinalysis blood workups. Can you suggest a specific test? Yeah, just a viral test, a viral screen. Have they done that? I mean, if you go to the IC Network website, you can search through it to find the actual research from our own National Institutes of Health, which has absolutely found polyomavirus in about 5% of IC patients. And polyomavirus is noted for its relationship to hemorrhagic cystitis. That when that polyomavirus gets turned on, it causes bleeding wounds in the bladder, aka a Hunner's lesion. And you know what? If you call me this week, I can email it to you. You just have to call me, okay? I love to chat. Danielle says you have to be your own advocate. Absolutely. Danielle's laying on her grounding mat on day 5. There you go. Renee says, is cognitive therapy similar? Absolutely. Gloria says, how am I doing? I'm okay. I'm on my quest. I want to lose like another 7 or 8 pounds, walking every day. But yesterday I was feeling a little, I just needed to do something not related to a computer. But I have ruptured discs in my back, and so it's like can't do the gardening I used to do. But I went and bought 13 bags of compost, and I spread it in my front yard, shredded redwood bark, knowing that you're going to pay for this, Jill. You're not supposed to lift heavy things. And it's like, I know, but I want to get it done. And so I did it. And last night, my right knee was numb, but it's fine now. So it is what it is. Anne says, I missed my answer, left the room. Can you use the wand rectally for constipation? Yeah, I would suggest putting it in a condom or even putting it in a glove, a non-latex glove. Use a little KY. That way it'll be a lot easier to clean. Sue says, I've been a guinea pig for 35 years for every treatment that never helped. That's why it's so important to go see a national specialist because there are so many uninformed doctors out there, and you could end up in the hands of somebody that is going to do more harm. Yeah. And Sue's story is a very, very important study because Sue, we really know now, Dr. Peters did find that you had this significant chunk of scar tissue in your pelvic floor in a very, very weird spot. He'd never seen that before, right? And so that helps us understand why pelvic floor physical therapy was so painful for you. But it also, as you said, you know exactly when that happened. You fell off a horse. So you're a trauma patient, just like just like so many other patients. Sue said, a torn hip and then a TIA during COVID left me very weak on the left side, and this has added so much more insult to my already messed up pelvic floor. Doing PT, it's been very challenging because of the weakness on the left side. It causes more pain. Yeah, honey, long COVID is a beast. Long COVID is a beast. Please, everybody out there, please, please, please understand that you should not be getting your COVID information from social media. COVID is starting to surge again, and we're getting much clear definitions of what long COVID is. It can cause dysautonomia, difficulty with your balance. It can cause blood clots that can lead to strokes, as Sue went through. The virus can live in your body for extended periods of time. And we had God, you know what? I put it out on my Twitter feed. God, this was such an interesting, it was a very, very interesting paper that came out this week. And this was a paper on HIV. And there's researchers up in Canada who are trying to figure out where the virus was living in the body. Because that's the thing about virus is once you have a virus, like herpes, it's usually there. You can suppress it with therapy, but once you stop that suppression therapy, the virus has the potential of surging again. That at least is the case with HIV. And so what happened up in Canada is they had some patients who had very, very severe HIV who were dying, and they asked them if they would consider donating their body to science, and they did. And the purpose of that was to find where the virus was living. The virus was living in the spleen. That's where they found it. And also living in some lymph nodes. And I shared that on my Twitter feed earlier this week because that's what we're going to need with COVID now too, is when all the vitriol stops and everybody just understands that this is a deadly virus that we've got to understand a little bit more. We're going to need that research with COVID too to try to figure out for patients who have long haul COVID where that virus is living. Remember that COVID is not a respiratory virus. COVID is a circulatory system virus. It attacks the blood vessels. And that's how it gets throughout the whole body, is it attacks blood vessels. And when you attack blood vessels, you cause blood clots to form. And when you have blood clots, you get strokes. And Sue, who's been a member of the ICN for many, many years, is a perfect example of that. I am so sorry to say. God, I wish I had a private plane and I could just fly to each one of you guys and just show up at your airport and give you a hug. Sit with you for a while, spend a couple of days. Carol says, would those shoes help plantar fasciitis? Yeah, they're Hoka's. I'll write it down. Hoka. And the style is Bondi. They have lots of style. Jessica, is there a good probiotic that you recommend for IT patients? I need something non-dairy. You know where I get mine is I do a coconut milk yogurt. Coconut milk yogurt. I will do a couple a week usually. So that's non-dairy. Coconut milk should be good. If you're looking for a pill, it's very important to just mix it up. Don't just keep taking the same probiotic day in, day out for years. Your flora is diverse. Diversity is important. So if you're taking a probiotic as a pill, I say mix it up. You know, a couple months on one, couple months on another, couple months on another, and let's just try to mix it up a little bit. Jeff says, would be tomorrow be okay? Possibly. Mondays are normally my day off. But I'm usually answering the phone afternoon on Mondays, at least this summer. So we can try. If not tomorrow, we'll connect this week for sure. I'm not sure what's going to happen tomorrow. I leave it as an open day. But Tuesday through Friday, my schedule is wide open. I have no appointments this week. So I have no appointments where I've got to be out of the office this week. Praise God. No dental appointments, nothing. What do I think about Botox? Virginia says, what do I think about Botox? I'm 78 years old. If you look at the guidelines, our AUA guidelines, Botox is really ideal for patients who have urinary frequency urgency. There are mixed uses for Botox. You can use Botox also in the pelvic floor if you've got a super, super tight pelvic floor. The challenge with Botox for a woman of your age, Virginia, is that they always run the risk of silencing the nerves that help you urinate. You know, so if this is your bladder and they have their Botox needle, they will just put it in random places in your bladder wall and in your trigone. And so there's no, and you have to remember that our nerves are all slightly different. I mean, it's like a bowl of spaghetti going all sorts of different ways, kind of, sort of. And so it's not like they know to go to exactly this one spot, because your nerve might be 2 millimeters to the left of that spot or 2 millimeters to the right of that spot. If they accidentally hit the nerve which controls your ability to urinate, then you might need to self-catheterize for a couple weeks or even a couple of months until the Botox wears off. The Botox will wear off, but the evaluation criteria, according to the FDA for Botox, is this patient capable of self-catheterizing? If you are, power to you. It used to be a common side effect of Botox. Now that they've reduced the dosage of it, it's less common, but it is possible. And I've worked with many patients that it's happened to. So you need to ask yourself, would I be able to self-catheterize? The other thing, Virginia, that I would say to you is you have to remember, in a woman of your age, if your symptoms started in the past 25 years, then odds are you are an estrogen atrophy patient, genitourinary syndrome of menopause. And because you don't have that estrogen anymore, your bladder's ability to defend itself is now compromised, because you need estrogen to produce that nice, thick, protective coating of mucus in your bladder wall. But your estrogen levels have been dropping massively. And there are many of you out there whose symptoms begin in your 40s, for women in your 40s or in your 50s, and it just relates to skin health. So is Botox an effective therapy for an estrogen atrophy patient? No, I don't think it is, because I think the most important thing that you have to address is skin health. So how do we improve our skin health? With estrogen, that when you give that skin estrogen, it plumps up and starts to produce mucus. It's like putting a raisin in water, it plumps up. Well, the same thing happens to skin cells when you give it estrogen. It plumps up and starts producing a good layer of mucus. So I would want to make sure that topical estrogen is part of your treatment protocol. And if not, I would ask the doctor, why not? And then this is where Elmeron used to shine, but now, Elmeron's not popular anymore because of these very, very severe adverse events they found. We don't want you to lose your colon. We don't want you to lose your eyesight. So most patients looking for that coating effect are going to the supplements Cystomend, Bladder Builder, Bladder Rest, which you can find over on the IC Network website. And they've done that for years now. I mean, because Elmeron got so expensive 15 years ago that many patients couldn't afford it. So this has been a transition that's happening for well over a decade now. Sue says, what are the pros and cons of using regular estradiol cream versus compounded? I used regular estradiol, don't seem to have it. Well, they're both regular estradiol, hon. The only difference is the base. The problem with a mass market estradiol that's like Premarin or Estrace is that the company creates these products with a long shelf life. So how does it have a long shelf life? They use preservatives. And it's the preservatives that can be irritating to some patients. So it's the same exact estrogen. They're both estradiols, but one is in a preservative base and the compounded is not in a preservative base. So if you're sensitive to chemicals, then that's the direction we want to go, is going with a preservative-free base. Sue says, I started wearing the more expensive Dr. Scholl inserts and very good shoes because my ankle rolls in like that on one side, and it does make a huge difference, except I find it very difficult to go barefoot now. You know what I got? I got these Nike slip-on shoes that are just fabulous. Let me go get them. Hold on. So, one of the things that I've wanted to do for a long time is just keep my regular shoes outside. I mean, the only reason I'm wearing these shoes is that they're new and they're not dirty. But my floors were always so dirty because I'm outside a lot. And so now I keep all of my tennis shoes outside, and on the inside I wear these, which are Nike Gel um, shoes. These are incredible. And they're so much better than, I ordered a pair of Crocs and they weren't cushioned enough. These are really soft and cushiony, and they come in white, blue, and black. They're sold out on the Nike. Where were they sold out? They were sold out on Amazon or the Nike website, but then I bought it on the other website, and I bought 3 pair. They were only like 30 bucks. These are the bomb. I love them. All right, hold on, you guys. I'm still catching up. Hi, Angie. Thank you for the 50 stars. Okay, so hold on a sec. I'm catching up. Nicole, I see you're posting, honey. Don't take it personally. I will get there. I promise you. Okay. Sue says, are we dry here this far? You've had water recently, or is it? We're already in November weather. It's just crazy. It's been a cool, wet summer. We're still having fires every day, but they're not terrible right now. They're actually predicting snow in the Sierra Nevada next week. Nicole says, I've been watching your videos for a while, but I haven't made it on time to a live stream. I've been having frequency without urgency, painful muscles in the sides of my pelvis in the front, and also about a week ago. Also about a week ago, I had very painful urination, worse than it's ever been, but it's gotten better in the morning. Doctors thought it was a bladder infection or yeast, but test came back negative. I get lower back pain, bladder pain too, before and after peeing, it seems. Well, honey, you have painful muscles on the sides of your pelvis. So the most important question for you is, what's going on with your pelvic floor? Have you had a proper pelvic floor assessment yet? Sue says, please get vaccinated. Yes. Yeah, Sue lost her father to COVID. And she said it collapsed her lungs. I was hours away from death as I was caregiving to parents with cancer when it got into the house, and no one knew what was happening to me, including myself. I feel hopeless because the gynecologist tested me and my GP test came back. When it comes back normal, I'm left to rip my hair out. I'm 22 years old. I appreciate everything you do. Okay, so Nicole, at the age of 22, the very first thing we're always going to consider in a patient of your age is trauma, specifically pelvic floor trauma. So, is there any event that you associate with the onset of your symptoms? A fall, a car accident, having sex for the first time, a rape. Can you remember, were you involved in sports, dancing, ice skating, football, cheerleading? Cheerleading really tweaks the pelvic floor if you're doing flying splits. And so now, according to our new guidelines, every patient who's being diagnosed at that very, very first appointment should have their pelvic floor muscles tested. And if their pelvic floor is tight, the AUA guidelines say that patient is to be immediately referred to pelvic floor physical therapy. And so I want to know what's going on with your pelvic floor. I mean, the good news here, let's check the good news for what it is. Your urinalysis is clean. Good. That's great. But you gave it away. You've got pain on the sides of your pelvis. Why? Those are joints. That's near joints. That's going to be related to muscles, nerves, and bones more than likely. So again, is there any event that you associate with the onset of your symptoms, or were you an athlete when you were younger? Sue says, is coconut milk yogurt sour? Like, no, it's not. Not really. I wouldn't say it's sour. Oh, Nicole, you don't need to apologize. She said, sorry for being late. Honey, you don't have to do that. It's okay. It's always an adventure. You know, yeah, it's an adventure for me even starting up the stream because sometimes I'm logged out of everywhere and I've got to reset all my passwords. Sue says, do they come in black? Yes, they do. I have a black bear too. You got to try them. Okay, so Nicole has not had a pelvic floor assessment. She wants to though. Nicole, there's a great website, pelvicrehab.com. Let me put the link in for you. This is a searchable database of physical therapists. Oh, here, hold on. That have got the training and certification in pelvic floor work. So you can search it by your zip code. And if there's one within 2 hours, go. You need to have a proper pelvic floor assessment. Marie says, what do you think of sling urethral surgery for slight urinary stress incontinence? It happens when I go for a walk, carry groceries, sneeze, or cough. Marie, girl, I got to tell you, for the first time, it happened to me when I was walking last week. Like, I didn't feel the need to urinate at all. And all of a sudden, I felt a little droplet come out. And I went into the bathroom at the park, and by golly, a droplet or two had come out. I couldn't believe it because that had never happened to me. The only time that I've only been incontinent, the last time I was incontinent, a dog was chasing my cat and I was running after them and I slipped and fell and my entire bladder emptied. Oh, so embarrassing. But for the first time, that happened to me last week, which is now why I wear a mini pad. So before you start thinking about sling surgery, what about physical therapy? Have you done physical therapy to work on your levator ani muscle? Surgery is always going to be the last result. I want to know what's going on with your muscles. Jessica says, are there any good products for chronic constipation? Number one, with chronic constipation, you have to understand that if you have tight pelvic floor muscles, that's going to contribute to constipation. Because that's what makes the pelvic floor such a unique group of muscles, is that these are the only skeletal muscles in the human body that control major bodily functions. There's 3 holes in your skeletal your levator ani muscles, which are the lowest level. There's a hole for your bladder, your urethra, there's a hole for your vagina, and there's a hole for your rectum. But the muscles wrap around each sphincter. And so if these muscles are tight, what are they going to do? They're going to squeeze your urethra. They're going to squeeze your rectum. They're going to squeeze your vagina, which is why sex is painful, which is why it's hard to start your urine stream, and which is why some patients struggle with constipation. So we have to make sure to check to see if muscles are playing a role in your constipation, because if they are, physical therapy is going to be very important and very effective. And the most effective thing you can do. You can eat all the fiber you want, but if your muscles are tight, you're still going to have trouble peeing and having bowel movements. Now, with respect to a product, the product that I use when I'm feeling a wee bit plugged up is Heather's Tummy Fiber. Now, you have to remember the golden rule. You got to have 20 to 25 grams of fiber a day. I made pasta last night, and I put frozen peas in with my noodles as they cooked. My pasta was great because it was gluten-free pasta with a heavy serving of peas, which is a good source of fiber. Okay, so Heather's Tummy Acacia Fiber is the bomb. No flavor to it, no scent to it. You can put it in anything. You can put it in pancakes. You can put it in soup. You can put it if I go to bed and I'm feeling just a little bit stopped up, sometimes I'll put it in a shot glass with water, warm water, and I'll stir it up, get it really, I'll get it really a good solution in there, and then I'll just pound it, and it doesn't have a bad flavor at all. Nicole says here, Nicole, I broke my leg at the age of 6 when wrestling with my brothers. I used to get thrown down to the ground a lot. So we have seen this before, Nicole, with children who've had broken legs. So what happens is the broken leg is now slightly shorter. And so that's one thing that the physical therapist should do is they will measure the length of your legs. Because if you have one leg shorter than the other, then your hips are going to be tilted. And we need your hips level. And so my right leg is like a quarter of an inch, third of an inch shorter than my left leg. And so I have a little insert underneath my shoe insole just to make sure I've got my hips really level. And what's so interesting is that, I only started doing that maybe 2 years ago. And so much of my SI joint pain and my muscle pain is now gone because I'm no longer walking like this. I mean, yeah, that's exaggerated, but I'm now walking with my hips level. And it shows because I can walk for miles and miles now and I'm fine. And it's really the only time now that I get SI pain, and it happened the other night, is I was laying on my couch on my side and I didn't have a pillow between my knees. So if you're laying on your side and you know how you tend to have your legs together, kind of like fetal position. So your thighs are together. I mean, your legs are like this, right? So you got your thigh and then you got your foot. Well, if these are your upper legs, your thighs, and you're laying on your side, if you don't have a pillow at your knee, what happens is the upper leg points down, which stretches out the muscle up at the top. And so for side sleepers, it's really important to have a pillow between your knees to keep your legs parallel. So if you don't have the pillow, this happens, which then stretches the muscle right here. And boy, when I woke up that morning, whoo, hello, Tiger Balm. I had that searing pain in my SI joint. Danielle says, I like to rip my pelvic floor out. No, honey, no. You need your pelvic floor. We're not ripping anything out. We're just going to rehabilitate it. Sherry says, what number is your Hoka Bondies? I noticed there are several numbers of the Bondies. I don't know. Size 9B. I mean, these are the Bondi 8s. These are the Bondi 8s. I have several Bondi 7s, but you can't get the 7s anymore. So these are now the next generation Bondi 8s. And you can see from the top, they really have a lot of wideness up here. I mean, these feel like clouds when I walk. Oh, it's just fabulous. All right. Danielle says, I love my heart-shaped leg pillow. Yeah. Sue says, I have the second toe longer than my big toe. That's called Morton's toe. Morton's toe. And I do the moleskin thing in my shoes now, and I have noticed my feet are more comfortable. It was a good book. Yeah, I do the same thing. I haven't done it on these new ones, but all my other ones have the moleskin. And I have moleskin in 3 spots actually now. Nicole says, can childhood injuries cause symptoms such as these so much later? Absolutely, hun. Absolutely. See, the thing is, Nicole, is that when you're a kid, you're very resilient. Your body's very resilient. But in your 20s, you start getting wear and tear injuries, and those childhood injuries are now a source of constant stress that over time takes a toll on muscles. And so childhood injuries, classic risk factor for anybody with pelvic floor dysfunction. And if you were sitting in my at my desk here, you would be amazed at the number of patients who had injuries in childhood. Absolutely amazed. Marie says, I have had pelvic floor physical therapy, but I have to admit, I have not been consistent with exercises long term. The doctor recommended a pessary and surgery. She does not believe the exercise or Kegel are very helpful. Well, okay, Marie. It's all about the condition and health of your muscles. If you have very weak muscles and things are starting to fall out of position, that's when the first thing you would do is a Kegel, because a Kegel is designed to strengthen muscle. So for anybody who's just struggling with incontinence, they would generally have you start doing Kegels. But that's exactly the opposite of what most pelvic pain patients do. Because for most pelvic pain patients, our muscles are not weak, our muscles are very tight. And the last thing we want to do is do a Kegel, which will tighten muscles that are already too tight. In this case, what we want to do is release the muscle. So when I had my pelvic floor assessment years ago, this is what they found. So normally when they do that assessment, they will go in and touch muscles, right? Just to get a lay of the land. And then they will have their finger in your vagina and they'll ask you to do a Kegel, a couple of Kegels. And it's all about seeing how well you contract and how well you relax. So my muscles that were very shallow around my urethra were very tight. Makes sense. I was diagnosed with a urethral stricture and they used to force my urethra open. Okay, so that makes sense. But the muscles that were deeper up were very weak. So the tight muscles were compensating for weaker muscles that were high up. And the weaker muscles high up were my piriformis muscles, my obturator muscles. And so the way a physical therapist would normally approach a patient like me is the first thing we want to do is we want to get those muscles out of tension, get these levator ana muscles to relax, and then they start building a strengthening program. Once we got those muscles relaxed, now we've got to strengthen them and get them healthy. So it's not one or the other. It's about responding to what's happening with your muscles specifically and uniquely. I can tell when my muscles are jacked up right now. When I got up this morning, I could feel, just when I went to urinate, I could feel that my muscles are moving back into a tension pattern. I couldn't start my stream easily. And it just feels very congested. I mean, it's hard to describe what it feels like. But I know that this is telling me that my muscles are starting to get tight again, and I've got to get on my wand tonight, and I've got to use it again for sure. Sue says, I had mild PAD, which was my first symptom at 15, which I really didn't understand what it was. I started after a hard fall when a horse decided to not jump over a log, and I landed on my tailbone hard. And I wish I knew then. It's a hard thing to tell people when you're so young. Even as an adult, I didn't talk about it until I was in my 50s. Just another part of the injuries. I've had way too many falls off horses. And Sue, I've told you, I grew up with horses too. My sister was a fabulous horseback rider, and I was more barn crew, but I did pony club. I did English riding, and I had one very spectacular fall that was quite bad. And that would have been right around the time and my symptoms started in 7th grade. We had the horse in 7th grade, but I also broke my tailbone in 7th grade. Marie, getting back to you, honey, you have to be consistent. And your muscles will tell you if you're being consistent or not. Can you urinate on command? Are you stopping and starting? Are you dribbling? If you're dribbling, your muscles are tight. You got to get in there and do your exercises. Donna says, I'm gonna go buy some Hokas. You'll love them, Donna. You'll love them. And the great thing about the company too is that they have an excellent return policy if you don't like them. If you wore them for 30 days and you just don't like them, you can send them back. Virginia said you've been doing estrogen for 4 months. You've been using Sister Protect for 4 weeks. Also Valium suppositories. Okay. So the estrogen is going to help your skin. The Sister Protect is going to give you a bit of a coating effect, just like Bladder Builder and Cystomend. I think that I'm much more of a fan of Bladder Builder now. Cysto Protect is kind of an older formula. I mean, lots of patients use it quite successfully, but I do think the newer chondroitin supplements are a bit more effective, and they have more ways of helping. And Bladder Builder is, in my opinion, the best supplement on the market. Why? Because it has more methods of action, more ways of potentially reducing some of your pain and discomfort. Most importantly, PEA in it, which we now know can really calm nerves down. Sue says, could you talk about okay, pelvic congestion syndrome? Yeah, that wasn't the word I should have been using trying to describe my pelvic floor. My pelvic floor, when it gets tight, feels when I'm urinating, it's kind of numb isn't the right word. I'm not getting a lot of sensory input when my muscles get really, really tight. And there's a lot of stopping and starting, not being able to start my urine stream right away. It just feels thick. Like it just feels very thick in there. That's very different from pelvic congestion syndrome, because pelvic congestion syndrome, if you ever feel like you're carrying a bowling ball around in your pelvis, if you feel this weight, this heaviness that gets worse and worse as the day goes on, until by the end of the day, you can barely walk because you feel like you've got a bowling ball hanging out in your pelvis. That's pelvic congestion syndrome. And what that is varicose veins in the pelvis. It means that there's a very specific vein, I don't remember the name of it, that is well known for becoming engorged. So it's a varicose vein. And so blood ends up pooling in the pelvis in these big, wide veins. And that's what causes that heaviness. Pelvic congestion syndrome is easily treated, but you have to see a special type of radiologist called an interventional radiologist to do that. So again, if you got that sensation of heaviness, then odds are it's pelvic congestion syndrome. If you feel like there's something stuck inside of your body, a pulling sensation or a pushing sensation, that's your pelvic floor. If you feel like you desperately need to pee, but when you go to the bathroom you can't, that's a very, very pissed off bladder wall and or potentially tight pelvic floor muscles. Nicole said, another interesting thing is during intercourse, I sometimes have deep pain that makes me jump at first and friction. Girl, and then when you sit down for a period of time, you go numb. You just diagnosed yourself with pelvic floor dysfunction and pudendal neuralgia, honey. Classic symptom. If the muscles around the vagina are tight, sex is going to hurt. And whenever you have positional symptoms, whenever you have periods of numbness, pins and needles, that means you have a muscle so tight it's squeezing a nerve. You have pelvic floor dysfunction. You have to go get your pelvic floor checked. You probably have an entirely healthy bladder. It's probably all related to your muscles and nerves. And interestingly, it's the pelvic floor muscles that drive the symptoms of frequency and urgency. Danielle said, you'll reach out soon. You're in a very, very dark place. You know, Danielle, I recommend you put on Katy Perry's song Firework. I love her song Firework. Um, it's just this fabulous lyrics that help you see that you're important. I should play it. I just love that song. Katy Perry's Firework. The video is amazing. So whenever I'm feeling down, that's a song I'm going to put on. I'm also going to put on Joel Osteen. I'm going to listen to him. He always perks me up, gives me faith and hope that what I'm doing is important. Helps me see that I have a place in this world that's important. Just, you got to get out of that bedroom, hon. You got to open the drapes, let the sun shine in, and reach out to people. Make sure you tell your doctor that you're feeling very, very depressed. It's important. They need to understand that. Because, you know, it may be very helpful for you to talk with a psychologist who can perhaps give you some medication to try to ease some of that. You're not alone, honey. You're not alone. We're here and we want to help. Sue says, compared to prescription nerve meds, how much more effective is PEA compared to them? I don't know if we've had a head-to-head study. I've never looked at it. The advantage of PEA versus gabapentin is that there's no side effects. Very, very, very few, and there's no risk of addiction or anything at all like that with PEA. So, you know, what the American Urology Association has consistently said over time is, we want you to do the less risky stuff that has fewer adverse events before you go to the meds that come with more side effects. And so the AUA guidelines for IC, they want you to try the supplements before you get into the hardcore meds, you know, that are known for adverse events. So again, before you try the Elmeron, which is associated with so many concerning side effects, doing something like a Cystoprotect or Cystomend makes sense. And that's what the AUA wants you to do. Aileen said, I got through my endometriosis pain with Unstoppable by Sia. That's good. You know, listen, I love Disney. I love Disney. I watched 2 Disney movies last night. I watched Elemental, and then I watched the one with the emotions. I mean, I'm a kid at heart. I love Disney. And I love even the songs from Frozen. They really inspire me. Let It Go. And then what's the other one that's just so good? I don't remember the name of it right now. But if I'm having trouble sleeping, like last night, my TMJ was not happy. And I woke up at like 3 a.m. with my jaw on fire. And my TMJ is caused by very, very tight neck and tight shoulder. And my neck's been out of control. And so I was really having trouble with my TMJ. And I just went back. I usually put Frozen on my iPad and fall asleep from that. Yeah, I go to sleep with kids' movies. I do. Sue says, some of the things we're the most afraid of because of past experiences, conquering that fear. And for me, it will always be getting justice. It's very healing. I'm going to walk that walk till good. Yeah, Sue, you know, you got to be, you're entitled to defend yourself. You're entitled to be righteous. You're entitled to speak out when somebody isn't treating you well. I mean, that's what IC Awareness Month is all about. You know, and the whole way we've designed IC Awareness is that when you look at your environment, when you look at your community, how are you treated? If you're not treated well, we've got resources and tools that you can use in your community to educate over at icawareness.org. Has anybody printed out the press release or copied it and sent it to your local paper? Anybody? What's it going to take? It's, if not you, who? If not you, who? Listen, it's the IC patients who have to speak up, share our stories, and demand better care. And the best way for you to use that pain is to express it. If you're up in the middle of the night and you can't, and you're in a lot of pain, for God's sake, write a letter to your senator or your congressperson or your mayor. I had somebody call me who is trying to work with her town because businesses were not letting patients use bathrooms. And she wanted to do some advocacy for that. And that's been a theme that we did several years ago with IT Awareness Month. Kayleen says, I got off of gabapentin because of the side effects, so PEA would be good for me. Yeah, it might be. I would give it a shot. I mean, the research that here, you know what? Hold on. Let's just go through some research studies real quick. Here, let me just go to the National Library of Medicine, which is pubmed.gov. And I'm going to type in the palmitoyl ethanolamide. I obviously have that memorized. And I'm a geek, so I remember things like that. Okay, so palmitoyl ethanolamide and pain. Okay, study number 1 in pharmaceutics. PEA has been demonstrated to improve pain in preclinical contexts. The primary outcome was pain reduction measured with a pain assessment scale. Okay, so there's a lot of papers here on pharmacokinetic safety and efficacy. Let's look and see what that says. That's in the British Journal of Clinical Pharmacology. PEA has been suggested to have analgesic properties and to be devoid of unwanted side effects. Here we have examined critically this contention and discussed available data concerning the pharmacokinetics of PEA and its formulation. 16 clinical trials, 6 case reports and pilot studies, and a meta-analysis of PEA as an analgesic have been published in the literature. For treatment times up to 49 days, the current clinical data argue against serious adverse drug reactions at an incidence of 1 out of 200 or greater. The available clinical data supports the contention that PEA has analgesic actions and motivates further study of this compound, particularly with respect to head-to-head comparisons of unmicronized versus micronized formulations. That's one of the debates right now. Should it be micronized, very, very tiny? Peora is not micronized. That's what I take. Here's one, the effect of PEA on pain intensity, central and peripheral sensitization, and pain modulation in healthy volunteers. Let's just go right to the results. The aim of our study is to provide a deeper understanding of the involved mechanisms, which is essential to differentiating therapeutic approaches and the establishment of mechanism-based, yada, yada. They did a randomized, placebo-controlled, double-blind crossover study of 14 people. PEA, three times 400 per day, or placebo. Our study investigated the mode of action of PEA using an established pain model, which is repetitive phasic heat application. In other words, they put something hot on somebody's arm or whatever to see if the PEA was helping that. And repetitive heat pain was significantly decreased, and cold pain tolerance was significantly prolonged after the PEA treatment. The pressure pain tolerance and condition pain modulation were increased after PEA treatment. The wind-up ratio and average distance of allodynia were significantly decreased after PEA treatment. The heat pain and tolerance was significantly higher after PEA. The present study has demonstrated that PEA has clinically relevant analgesic properties acting on both peripheral and central mechanisms, as well as in pain modulation. That was a study last October. There are so many studies on this. Let me just see if I can find. Here's a study on orofacial pain. PEA in the treatment of chronic pain. There's so many papers, guy. There's so many. Here it is on nerve compression syndromes, the efficacy and safety of sciatic pain and carpal tunnel syndrome. Oh, here, let's end with this one. I mean, let's end this discussion with this one. PA, let's see. Here we describe the results of clinical trials evaluating PEA's efficacy and safety in nerve compression syndrome, sciatic pain, and pain due to carpal tunnel syndrome. Both pharmacological studies as well as clinical trials supported PEA's action as an analgesic compound. In total, 8 clinical trials have been published for such entrapment syndromes, with 1,366 patients included. PEA proved to be effective and safe in nerve compression syndromes. In one pivotal double-blind placebo-controlled trial of 636 sciatic pain patients, the number needed to reach a 50% pain reduction compared to baseline was 1.5 after 3 weeks of treatment. Furthermore, no drug interactions or troublesome side effects have been described. Physicians are not always aware of PEA as a relevant and safe alternative to opioids and co-analgesics in the treatment of neuropathic pain, especially since the often prescribed co-analgesic pregabalin has proved to be ineffective in sciatic pain. PEA should be considered as a new and safe treatment for nerve compression syndromes. There you go. That is from the Journal of Pain Research. And that was actually more than 5 years ago. And where is that research done? The Netherlands. PEA is a great resource. Good luck, Virginia. Keep me posted, hon. Let me know how you're doing. Valerie said, did the tibial nerve stimulation help with pain? I'm going to have that treatment soon. Frequency has been 30 times a day, praying it helps. So Valerie, again, this is all about cause versus effect. It's hard to know what the right treatments would be for you until we understand what's causing your symptoms in the first place. So you could do all sorts of neuromodulation, bladder treatments, and they might not work if we don't have the right phenotype for you. And so, so that's the future right now. Everybody now acknowledges that we're not all the same. Some people have Hunner's lesions, but most don't. Most patients have tight pelvic floor muscles. And then we've got this really core group of patients who have widespread pain, which is all about the central nervous system. And we've got another group who have estrogen atrophy. So we want to try to understand what your phenotype is to see if that's going to be a successful treatment for you. I was one of the very first patients who ever did tibial nerve stimulation. So what is my subtype? My subtype is pelvic floor widespread pain. I have a healthy bladder. I had that, this was the summer of 1993, that long ago. I had my first 2 hours without pain at week 3, and I had my first day without pain at week 7 or 8. So I do believe that the tibial nerve stimulation played a very important role in helping to break me out of a wicked flare. But it's not a substitute for pelvic floor. I still had a lot of ups and downs while I was doing tibial nerve stimulation. But once I started the pelvic floor physical therapy, it just went up. I mean, I just got so much better. And that makes sense. So what the tibial nerve stimulation did is it calmed the nerves down temporarily. But we have to figure out why the nerves are jacked up in the first place. And usually that's because of tight pelvic floor muscle. Sue said, I was on Elmeron during the study phase, so I got it for free anyway. I'm glad it made my hair fall out, so I quit using it, but I did not have to pay for the meds. Yeah. Marlia said, I'm so dry and was using estradiol 0.01. Asked the doctor to switch me to estradiol 0.05. I applied a pea-sized amount to the inside of the vulva and my finger. Saturday afternoon, I had a light color pink when I urinated. That's interesting. Burn on wiping. Tuesday, took a urine sample, was told the dip saw a little something. By Thursday, they said no bacteria. I finally calmed the urgency frequently down. somewhat normal, only a slight burn with the new compounded Cystitis caused that kind of a reaction. Only thing different is I did eat a homegrown tomato sandwich. Aha, girl. What? You're super dry. Your bladder can't defend yourself, and you had a tomato sandwich. Ah, we've all done that. Not the best thing. Not the best thing for you to right now, even though it's so good. Do you think it was the tomato or the new compounded cream? I think it was the tomato. Again, you're very, very dry. So how does dry mouth feel? You know what happens when you get dry mouth and it burns and you just have to sip water all day because it's just agony? Well, dry bladder feels exactly the same way. Dry urethra feels exactly the same way. Because you don't have that wetness, you don't have that mucus, your bladder's ability to defend itself is greatly compromised. And so, yeah, that tomato probably burned like hell when it arrived in your bladder because you just didn't have mucus. So it's far more likely that the tomato irritated the hell out of your bladder than it would be the estrogen cream. But I'm not going to rule that out because it depends upon what they made it with. If it's a preservative-free estrogen cream, you should be fine. But sometimes they put wacky things in that estrogen cream, like alcohol, that could burn. But I've never heard, I'm trying to think, like I got this memory tweaked. My memory's being tweaked by something. Can topical estrogen cause bladder bleeding? I don't see how it would. I don't see how it would. But in the same sense, I'm getting tweaked. Hold on. Let me look something up here real quick. Are you sure that it was in your urine or was your toilet paper pink? No, nothing's coming up here. If your toilet paper was pink, but I mean, hopefully you have a white toilet. So was your urine pink in the toilet or was the pinkness only on your toilet paper? If the pinkness was only on the toilet paper, there is a chance that the estrogen might have irritated your skin a little bit. Again, because of a filler. But estrogen, again, it's like putting a raisin in water. When you give these tissues estrogen, they plump up and they start getting wet again and producing mucus again. But sometimes you have to get through that burn, get through that first week where it can be a little bit more uncomfortable. Nicole said, I was in so much pain with burning and frequency 6 days ago at night to where I was at the edge of my bed, almost in tears and frustration. Boyfriend was at work till 6 a.m., so I was not able to lean on him. I went to your videos and just listening to you talk about these kind of things really brings me down to, oh, honey, I'm so glad. I cannot wait to get my pelvic floor examined. Yeah, girl, your pelvic floor is jacked up. I'm sure. Valerie said, you didn't have a frequency issue. Estrogen atrophy manifested for me in a very, very strange way because I felt it in my urethra. I was like 52 and it felt like there was a drop of urine in my urethra that would not come on. Hello, Malia. So again, I started feeling like my urethra wasn't emptying properly, that there was a drop of urine stuck in there. No matter how much I pushed, it wouldn't come out. It wasn't in my bladder, it was in my urethra. And over a period of about 3 months, I threw the book at it. Everything I knew, all my IC self-help tips, nothing stopped this urethral irritation. And I finally threw myself on the mercy of Dr. Klein. And I said, please help me. What the hell is wrong with my urethra? And he took one look and he goes, Jill. And I'm like, what? Laying on my back. He got my feet in the stirrups, looking at his face through my knees. What? What'd I do? And he goes, didn't you use your estrogen cream I prescribed for you last year? And I went, no. And he said, why? And I said, because in my brain, I'm 25 years old and I can't possibly have an age-related issue, which is exactly how I feel, even though I'm 10 years older now. And he said, I saw this happening last year. That's why I prescribed it for you. I was trying to prevent this from happening. And then he explained that the urethra is kind of the canary in the coal mine when it comes to estrogen atrophy. It's the first part of the urinary tract to start screaming when your estrogen levels drop. And so he gave me the prescription and he said, I want you to rub a pea-sized amount directly into your urethra. I had an appointment with my gynecologist the next day, Dr. Bennett. They're both retired now. And I said, okay, do you agree with him? He goes, of course, Jill. Yes. And he's the one who said, we're going to do compounded cream. You're too sensitive. And it took 2 weeks of just using my estrogen for my urethra to completely calm down and for the symptom to go away. If I don't use my estrogen for 2 weeks, the symptom comes back. My urethra starts getting irritated again. So Kristen said that's where my GSM symptoms are too in my urethra. Yeah, I mean, it's very, very interesting. Marlia says her toilet paper is pink and the drip, there was some pink to the drip. Well, in my opinion, anytime you've got blood in your urine, you have to let your doctor know. I would want them to do a urinalysis and to try to figure out what's going on there because I don't again, my memory is being tweaked by a paper probably 20, 25 years ago that mentioned this. But I would want you to have a proper urine test. They need to look. And let's just make sure that your urine is healthy. Do you have a Hunter's lesion that's bleeding? Is there something else that's bleeding in your bladder? I don't see the estrogen causing that. I just don't. I just don't see that. Kristen said, could the estrogen have provoked some uterine bleeding? No, usually it's the drop in estrogen that causes uterine bleeding. It's the progesterone that causes uterine bleeding. But we're all different. Anything's possible. I will tell you that I had a very pale pink discharge. I started using my oral estrogen when I was about 52. And the reason why is because I was having a lot of muscle cramps and I was having trouble with words and I was just feeling the effects of menopause. And we have no history of cancers in our family. So I'm like, I want to give it a shot. And I love topical. I mean, I loved oral estrogen. I felt great. My skin cleared up. My skin got stronger. My memory got better. And I used it for 5 or 6 years. And then I started spotting a very pale pink discharge. Very, very pale pink. It looked like pink lemonade on my toilet paper, but it was coming from my vagina. It was not coming from my bladder. And, I called my doctor and said, hey, I got this pink discharge. What do you think? He goes, well, you should come in and we should look. And then he's like, you're on estrogen. It's probably just the estrogen. And I said, well, he said, we should do a biopsy just to be sure. And I'm like, I don't really want to do that. Well, fast forward 8 months, and it was actually early uterine cancer. And from the oral estrogen. Topical estrogen is considered safe. Oral estrogen definitely comes with risks. And, this terrible, there's a video of me coming home after my hysterectomy here on YouTube somewhere, I think. and me crying, telling my story. It was a huge mistake not to let fear stop me from getting that checked out. We didn't check it out for another. I didn't have a biopsy for like another 8 months, and woo, boy, your life changes in a moment when that happens. So I would want to get checked out. Okay. And I'm fine now. I had a total hysterectomy and it was very, 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 very early and we nipped it in the bud. Knock on wood. I did ask the doctor, I said, wait a second, we have no history of cancer in our family, both sides. I don't have a single living family member who had breast cancer, cervical cancer, uterine cancer, none. And I said to him, I said, how is this possible? And he goes, Jill, genetics don't matter anymore. It's really about, do you have cells that get turned on by estrogen? And you did. And that's why this happened to you. So Susan's saying, does anybody use the estradiol pill vaginally? My gyno prescribed it and it has seemed to work. I'm 75. I use it 3 times a week. Lots of people use it. Lots of people use the estrogen insert rather than a cream because it's less messy. The disadvantage of the pill is that you can't rub it on places that are acting up like your urethra. That's why the cream is a little bit better. I mean, you just have more flexibility with the cream. But girl, if it works for you, it works for you. Danielle said, I take a gram a day of estrogen to help with frequency at night. And if I don't take it, I'll be up all night. Okay. Valerie said, thank you for all the great info. You're welcome. You're very, very welcome. Marlia said, they did the urinalysis and they have done scopes and a CT scan. The urinalysis showed no bacteria. And the symptoms have subsided now, but I had great hopes for the new compounded estriol from the compounding pharmacy. Well, let the compounding pharmacy know that you had a little bit of bleeding, and let's see what they've got to say. Danielle said, before I had my uterus taken out, they told me I had 4 uterine fibroids, but ever since the surgery, I've actually gotten worse. I think they cut through nerve endings or something because the pain is ungodly. Danielle, the odds are it's your muscles. I went into severe pelvic floor spasms for a year. They were called involuntary levator ani spasms after my hysterectomy. It felt like there was a hand up inside my vagina grabbing onto where my cervix used to be. So grabbing onto that very tender surgical wound and trying to pull it out of my body. This pulling sensation whenever I sat down, especially if I sat down in a car. And that it was a spasm of the levator ani muscle, but pelvic floor physical therapy got rid of that. Nicole says, I'm glad it was caught and that you're okay. Thank you. Danielle, thank you so much for the 50 stars. Yeah, I am too. But, I mean, I remember in high school, we had a teacher who said the greatest gift that a woman can give to a man is to risk her life to bear his child. And that really resonated with me because being a woman is challenging at times. It's scary at times. Pregnancies can cause all sorts of injuries and traumas, and maternal deaths. And the same is true for kind of all the things that can happen sometimes, whether it's ovarian cysts, fibroid tumors, endometriosis. It's not easy sometimes to have problems going on down in the pelvis. And it's a very complicated area. And that's why, again, this book is, in my opinion, the book. This is the book. When you go to a physical therapist and you're laying on your back and they've got their finger in your hoo-ha, I want you to be able to visualize exactly what they're touching. I want you to be able to use the muscle names. I want you to be able to ask, what are you touching? Is it my levator, my obturator, or my piriformis? And And when she says my piriformis, you're going to remember from reading this book that, okay, that's a deep muscle to help keep the SI joint together. Huh, it's tight. Interesting. Why? Huh, right? You're, this is about empowerment. This is about becoming a very strong, educated patient because you're the team captain. Your doctor's not the team captain. You're the team captain. You pay them. They don't pay you. You're the boss. You're the ones who should be making the big decisions here. But you can't make a good decision without knowledge, and we've got to learn as much as you can. Malia said, you just had a cystoscopy scan that showed a lot of folds in there. Is this normal? Sometimes, yeah. Yep. I wouldn't be too, I mean, what the doctors say about it? That's one of the reasons why they put fluid in the bladder to kind of stretch it out a little bit so you don't get necessarily that folding. But there might be other reasons why there might be areas that are slightly higher than lower on the bladder wall. I've seen pictures of that. I wouldn't be worried about folding at all. I'm more worried about wounds and bleeding and redness on the bladder wall. Kristen said, I had a large open surgery to remove an orange side fibroid 22 years ago and had horrible muscle spasms. They were so bad I couldn't walk upright. It took massages multiple times a week plus muscle relaxants to get. Yeah, Kristen, exactly. Thank you. That's exactly what happened to me. I was walking around, the classic pregnancy pose. I had my hands over my pelvis as I was walking for months because the muscles got so jacked up. And of course, I'm messaging my doctor going, what is this? What is this? And he's like, Jill, your post-op recovery, it's fine. You'd be fine. Well, 10 months later, he finally agrees to see me, gets me up in the stirrups, and he gasps. He goes, wow, I can see your muscles trembling right now. And I'm like, okay, what the hell is it? He goes, these are involuntary levator antispasms. And I'm like, okay, what do we do about it? And he goes, physical therapy. And I'm like, sign me up. I'm in. And he's like, well, I need to let you know, most people drop out. Most women drop out because it hurts. And I went, number one, I'm not most women. And number two, I want to try. And he was right. It did hurt the first twice. I mean, so I got to tell you that I never found the physical therapy itself painful. I mean, I would kind of grimace. The physical therapist, as you're laying there, it's always looking at your face to just kind of see your facial expression because that gives them a clue if it hurts or not. I never really found the physical therapy itself, touching muscles, painful. It was weird. It wasn't painful. I felt the pain when she was done and I sat on the side of the bed. Then I went, oh, okay, something happened down there. And then just walking out to the car, that's when it started to hurt. And then sitting in the car, I burst into tears. First time I had it done after my hysterectomy, I sobbed all the way home. It was agony. And then I went straight to the recliner and some Norco, and I didn't move out of the recliner for 8 hours. 8 hours. And the irony is that, well, I kind of expected that. That's what happened. I had surgery. The nerves are raw. I went back. I told her what happened. We did it again. Then the same thing happened again. I sat in the car, burst into tears, and went home. I sat for a couple of hours, not 9 hours. But the third time I went to physical therapy, it didn't happen. It didn't happen. And that why? Because my muscles were responding. So pelvic floor physical therapy is the bomb. Nicole says, I have to retouch on my anatomy lessons from high school and relearn these muscles for where to go. So I truly know I'm a veterinary nursing student now, so it's a bit different. Yeah. Yeah, great career, hun. I wish you the best of luck. And I'm very, very impressed at anybody who can go work. I mean, you judge a society by how they treat animals. You're the best of the best if you're providing care for animals. So power to you, girl. Sue says physical therapy feels good when you're doing it, but then it kind of feels sore and painful shortly afterwards. After I do my PT every other day or work on my arms or upper body. Yeah. Danielle says, I just want to face away. I'm not afraid. I'm a medium since the age of 3 and suffering many years. I'll be 50 in November. Thank God. Yeah, honey. Okay. So I can remember, like 6 weeks after that surgery, I used my finger and I tried to put the estrogen up inside my vagina and I touched the stitches. Ugh. And I just, woo, and I just, oh my God, it was just, whoa, that was awful, absolutely awful. And I can remember I walked out into my kitchen. And it must have been after midnight. My dad was sitting at the table and I went, he's like, what's wrong? And I went, I just touched my incision. And it's like, why? And I'm like, I have to use the cream, but oh, the skin can get so sensitive. And he talks about that. He explains exactly why that happens in this book. And he also explains in this book that therapy isn't just going to be focused on calming muscles down. We have to calm the nerves down. And we can calm nerves down. One of the things, so he always, when he was doing diagnostic workups of IC patients and pelvic pain patients, he always did a skin assessment, not only for the health of the skin, but for nerve health, pins and needles, areas of numbness, things like that. Because the skin health is a direct reflection of what's going on with the pelvic floor. So if that pelvic floor is super tight, it's gonna harm the skin. Um, and he also found that some patients had severe pain right underneath the skin, like just like right underneath. When you grab onto some fat, and you get just like a little chunk of skin right underneath there. He ended up using a little bit of lidocaine directly under the skin to get the nerves to calm down underneath the skin. That was very successful. And then, of course, using things like lidocaine cream to calm the nerves at the skin itself was also very, very helpful. Malia says, yes, you have blood in your urine and you're scheduled for Botox. Visible or microscopic blood, Malia. If it's visible blood, like pink, you have to let your doctor know right away because that's pretty much that's a deep concern. If you're ever peeing bright red blood, that's a emergency. They got to get in there and figure out what's bleeding. Are you bleeding because you have an infection or are you bleeding because you have an open Hunter's lesion? Something like that. Microscopic blood, usually not a concern. Visible blood, absolutely a concern. And you're scheduling for Botox. Okay. So just remember with the Botox that, it's all about your phenotype. We have to figure out what your phenotype is to figure out if Botox is correct for you. Right? Because Hunter's lesion, is Botox successful? Not usually. Is Botox successful for the estrogen atrophy patient? Well, it might calm the nerves down, but it's not going to fix the underlying problem, which is dryness. Botox might be successful for very tight spasming muscles in the pelvic floor. Botox is not going to be successful for patients with widespread pain, which is a central nervous system problem. Oh, not a problem, Danielle. Sue says, I get pain across the top of my belly when the physical therapist does myofascial work. I don't know. Huh. Tell her. See what she's got to say. She's probably pressing on a nerve that reflects over the top of your belly. Probably. Hard to say. Okay, Malia here on YouTube shows she has visible blood in her urine. So is this brand new? Did this just start or did this start after you had a cystoscopy? Like, when did you have that cystoscopy with hydrodistension? Was it last week? Because if they did a hydrodistension with cystoscopy, then it's I'm not gonna say it's normal, but certainly you would have some bleeding and oozing after the cystoscopy. No, it's old. Have you always had blood in your urine that you can see, hun? Like, how long has this been going on? So again, we're simulcasting on Facebook and YouTube. So when I'm looking here, I'm looking at Facebook. When I'm looking over here, I'm looking at YouTube. So several months. And your doctor knows about this, right? That's unusual, honey. That's a very unusual to have visible blood in your urine for so long. So they need to do a proper diagnostic workup. Now, here's my theory. This is what I do for me. If I'm scared, if I'm in a lot of pain, I want somebody to look. I'm not interested in guessing anymore. I want facts. Like, I want you to look and tell me what's bleeding in my bladder. And there's nothing unreasonable about that request. Again, I want facts. I don't want guessing. I want facts. And so when we see visible blood in the urine, in fact, our AUA guidelines, they just expanded that section. They're telling doctors to take this very, very seriously. The first thing they want to do is something called a urine cytology test, especially if you're older, especially if you have a history of smoking, because blood in your urine is one of the early signs of bladder cancer. Now, and what's the number one cause of bladder cancer? Smoking. Um, so it's you just pee in a cup, they send it off, and they look for cancer markers. That would be absolute number one. Just to verify, if you are a smoker at any time, we want to catch that bladder cancer when it's very, very young. Bladder cancer is considered the easiest cancer to treat in the human body. It's actually quite easy to treat if you catch it early, like total cure rate. But if you allow it to linger, that cancer can grow beyond the bladder wall into deeper into the muscle, and that's when it becomes much more challenging. So I know. Okay, so you say no smoking. Were you ever around anybody who was a smoker? Were you exposed to a lot of secondhand smoke? Was there another smoker in your home? Were you in a career where there was a lot of smoking? Anything at all like that? Because secondhand smoke is just as risky as regular smoke. We know that children exposed to secondhand smoke can develop all the symptoms of frequency urgency. Kids at school. Okay. So, I mean, it's just a one and done. Just like I got blood in my urine. We just want to rule out a potential for bladder cancer. Now, the second thing we want to rule out at the same time is infection, because if you have a really, really bad bladder infection, that can certainly cause the bladder wall to bleed. And if your cultures come back negative and they're still and you're still bleeding, they're probably going to look for kidney stones, because kidney stones can cause bleeding. And it's a kind of at that point in time, I mean, they would do an ultrasound for that, something like that, to see if you've got any active stones going on there. And eventually they might want to do a hydrodistension just to get a close look at the bladder to see if they can figure out what's bleeding, because there should not be visible blood in the urine. So I would just take this very, very forcefully here. And I can give you the link to the AUA guidelines where you actually can read that for yourself, because these are in the IC guidelines. Hold on. Let me see if I can. I did a blog on it. Let me see. And you guys just, we put new blogs and articles on our website every week. We have a free newsletter. You can sign up if you go over to the IC network. And then, of course, we have our magazine, the IC Optimist, which is my baby, where we put our much more in-depth articles. And so to get our magazine, you have to pay for that, because that's how we pay for this. So $25 a year to read it by email, and more if you want it sent to you. Hold on, let me just get this link for her. So many articles. It's just like I have to scroll back. It was in spring of 22. You know what? Let me do this in a different way. Well, let's see here. Almost there. It's almost, here it is. There it is. Okay, Malia, here's the link. That's to the article I wrote, and then at the bottom of it is a link to the actual guidelines. You should look at the little section on blood in your urine, okay? Because that's how they want doctors to be evaluating patients like you. I was completely convinced that I had cancer my first year. And even though we did all the tests, we did the urine cytology, everything came back negative. And I'm like, this has to be cancer. I feel like I'm dying. And they're like, it's not cancer. And I honestly, I just said, I don't believe you. And I demanded exploratory surgery. I demanded it. I said, I want you to open me up. I do not believe that I do not have cancer. I feel like I'm dying right now. And he's like, really? And I'm like, yeah, open me up. I want a laparotomy. And I had a laparotomy an hour later. I mean, a month later. Dr. Bennett, love him. And I woke up in the recovery room and he went, Jill, we found nothing. You're not dying. You don't have cancer. And interestingly, so he's the one who did my hysterectomy 30 years later, 25 years, we're the same age. And so when I had my hysterectomy, he did a hydrodistension again to look at my bladder. And my bladder came back perfectly normal. And he took pictures of everything. And he goes, Jill, this proves from day one, it was never your bladder. It was always your muscles and your nerves. Always. And that's the take-home point. That's the point you really, I mean, you have to understand that I thought I was dying for months. The pain was that bad. I could barely walk. And absolutely believed that it was fatal. And it wasn't. And I'm pain-free now. Why? Because we finally walked away from the bladder. It was never my bladder. It was always my muscles and my nerves. And now that I've done the right therapy, the proper physical therapy to get my muscles to relax and release, along with calming nerves down, I'm symptom-free. So it's completely normal to think you've got cancer. And I'm telling you, there's no relationship between IC and cancer in any published study. Once in a blue moon, maybe once in 20 years, somebody might have been misdiagnosed with IC when they actually had bladder cancer, but it's actually quite rare. Danielle said, yes to nurse, barely able to walk for the past 4 years. Yeah. Yeah. So there is hope. Carry hope in your heart. It's all about learning cause and effect and trying to focus on underlying cause. You are an anatomical mystery to be solved. We got to figure out what the hell's happening in your pelvis. And for 85% of you, it's muscles and nerves. It's not your bladder. And if you've done bladder therapies for years and you're still flaring, why? Obviously, the bladder therapies aren't fixing anything if you're still flaring. I hope that makes sense. All right, guys. Well, listen, we've been doing this for about 2.5 hours now. So let's do a last call for questions. Last call for questions, because I want to go over to my local park and watch the dogs play in the lake. It's bark days, and it's the happiest thing I've ever seen in my life. And they stop at 4, and it's 3:10. So last call for questions. Last call for questions. I should be here all week. I don't have anything big scheduled. Nope. I'm wide open. I'm working on our masterclass. I'll be having a video out. We'll have our Meet the IC expert, Dr. Martha Boone, up this week. We will have an IC newsletter out later this week. We'll be working on our fall magazine and our IC masterclass. So believe me, I've got a ton to do. But thankfully, I love my job. Okay, last call for questions. Last call for questions. All right, we're going to call it here. I will see you again. I just want to go do something happy, and these dogs make me happy. So I will see you later. I'll see you next week. And for Facebook, maybe on Thursday or Friday for our drop in Facebook. All right, YouTube, see you later.